The topic of discussion in this lecture is uveitis and acquired syphilis. As usual, we are going to just start this topic with the introduction. Syphilis is caused by the spirochete bacterium, Treponema pallidum. In adults, the disease is usually sexually acquired. When the organism enters through a skin or mucous membrane abrasion, transmission by kissing, blood transfusion, or percutaneous injury is rare. Transplacental infection of fetus can also occur when the mother has become infected during or shortly before pregnancy. That is another category, which is congenital syphilis. We will only be covering acquired syphilis. Now, the systemic features. The natural history of untreated syphilis is variable. First of all, primary syphilis is characterized by a painless ulcer, which is called a canker, commonly on the genitalia or anus. Secondary syphilis consists of a maculopapular rash, as shown in the figure here, and other systemic features. Then there is latent syphilis, and ultimately tertiary syphilis, which occurs in about 40% of untreated cases and is characterized by cardiovascular manifestations such as Uveitis, neurosyphilis, and gummatous infiltration of bone and viscera. After that, there is the most important part of our discussion, ocular features. First of all, we are going to discuss anterior uveitis, which occurs in about 4% of patients with secondary syphilis. It may be granulomatous or non-granulomatous and is bilateral in 50% of the cases. Roseolae are dilated iris capillaries that may develop into yellowish nodules, as they can be seen here in this figure. These are dilated iris vessels here. IOP may be elevated. The next feature is chorioretinitis, which can be localized, as it is seen here. But is often multifocal, bilateral, and associated with vitritis, and exudative retinal detachment can ensue. After that, there is acute syphilitic posterior placoid chorioretinopathy, which is characterized by large, pale yellowish subretinal lesions in the posterior fold, as it is seen in the figure here. Since the vessels are passing over it, we can safely say that these are subretinal lesions, and they are present in the posterior polar area. It is thought to be due to retinal pigment epithelial infection and occurs more commonly in the immunocompromised patients. Retinitis has a ground glass appearance. Associated vasculitis may be occlusive and involve both arteries and veins. This heals, leaving diffuse chorioretinal scars, as seen in the figure here. There are multiple scars which are along the arcades. Then optic neuritis and neuroretinitis can also be present. Some degree of neuroretinitis or macular star is also seen here. And other features include conjunctivitis, episcleritis, and scleritis, intermediate uveitis, glaucoma, cataract, and miscellaneous neuro-ophthalmic features related to CNS involvement, including Argyll-Robertson pupils, which we are going to discuss in detail when we will study the neuro-ophthalmology. Afterwards, we are going to discuss investigations. Serology is the mainstay and is discussed uh, uh, we do treponemal antigen test and VDRL, systemic assessment by an appropriate specialist, including lumbar puncture to rule out neurosyphilis, HIV status should be established, uh, aqueous and or vitreous sampling for PCR is sometimes indicated when HIV positivity makes serology less reliable. Then there is this treatment phase. This should be under the supervision of a specialist in infectious disease, but usually consists of an extended course of parenteral penicillin. Alternatives may be required, for instance in penicillin allergy, but are less effective, and parallel confirmatory allergen testing and desensitization may be considered. Topical antihistamic steroids may be given in conjunction with antibiotics to ameliorate the inflammatory damage. The Jerisch-Herxheimer reaction is a systemic response to treponemal antigens released on the commencement of therapy and may include progression of ocular signs. Steroids might be helpful in that scenario. Uh, so that concludes the topic of uveitis in syphilis. Uh, we will be discussing rest of the topics now afterwards in the upcoming lectures. This concludes uveitis and syphilis. If you like the lecture, please press the like button and subscribe to this channel. Thank you all for your patience.